Hi, everybody. And we're going to continue with asthma this afternoon. And there'll be a little overlap because I wanted to make sure that we had a little, I rushed at the end of the last one and wanted to make sure we had the concepts clear. So this is the basic overview of asthma currently. And I think this is the most important slide that we have. So let's just run through it again because it really encapsulates much of the story right now. So on the x-axis, we have age of onset. So you have childhood onset, adult onset, and then on the y-axis, you have severity of disease. And as you can see, there are groupings of the types of inflammation seen up here at the top. So we have Th2 inflammation and we have non-Th2 inflammation. Okay, so this is sort of a strange way of describing something, but Th2 inflammation refers to those types of inflammation that are under the control of our allergic cytokines. So, and non-Th2 is more of a neutrophilic or lymphocytic type of immune reaction. So when we think of asthma, we often will think of childhood onset, which is allergic. They may have anaphylaxis, they have lots of allergies, and we know how to treat those patients. And traditionally, most of asthma treatment has been directed at the childhood onset asthma. We also have exercise-induced asthma, which falls into a similar category, often of young onset. As a person grows older, though, we start to see adult onset asthma. And what's very important about understanding this concept is that most of the biologics were developed in the hopes of treating adult onset asthma. Even though you can use them for childhood onset, their initial goal was to be able to treat adult onset asthma. And within adult onset asthma, they most specifically are looking at the role of the eosinophil and the role of of inflammatory cytokines that are under the control of either IL-4, IL-5, or IL-13. So within this grouping here, you are going to have the patients who have adult onset with eosinophils probably, possibly with IgE as well, but they're going to be adult onset and they're going to have more severe onset of asthma. As you go across here, we're going to come to the more of the non-Th2. So you have here the eosinophilic related asthma, and there's also aspirin exacerbated asthma. As we move across here to very late onset in women, obesity associated, smoking associated, and even smooth muscle mediated. These are forms of asthma that we do not have good treatment for. We do not have good understanding of the biology, and we don't have very good treatment. We know that obesity associated asthma is not as inflammatory in the traditional sense of eosinophils and IgE. They have leptin and inflammatory properties that are generated by fat itself. Smoking related neutrophilic, again, that's not going to be something that we would treat in the traditional way. And then we even very rarely have patients who fit into this category, which have paucigranulocytic asthma. In other words, they have very few inflammatory cells in their airway at all. And we don't even know if these are people who their asthma is burned out or why they have asthma. So there's the spectrum here, IgE over here, eosinophils over here, and then a variety of other pathways that are not in the Th2 or the allergic framework. So that means that asthma is more complex than we had thought previously. Our previous concept was what we call atopic asthma. And atopy refers to IgE. It does not refer in the definitions that we use in asthma. It doesn't refer to eosinophils. It refers to for the presence of IgE. So when we're talking about asthma, we're referring to a very bronchodilator responsive, usually of childhood onset, heavily allergic, lots of IgE, and not all asthmatics fit this picture, because we know many of the patients we see in the clinic or in the hospital, they develop their asthma as an adult. So the newer concepts emphasize age of onset, then they emphasize atopic, which means IgE, versus Th2, which includes both the eosinophilic and the atopic, versus this non-Th2 group, which is a completely separate and different form of asthma altogether. In the newer concepts, we also emphasize the presence of nasal polyps, because nasal polyps are a feature of adult onset asthma. When we're looking at our biomarkers, what tests we're going to do, we're going to look at a total eosinophil count. We're going to look at an exhaled nitric oxide, or FeNO. We're going to look at the total IgE. And if we're going to look at sputum, we're going to look at the presence of eosinophils versus neutrophils. And if we're going to look at airway biopsies, we're going to look at the presence of eosinophils versus neutrophils versus very few cells. Now, you know that we do not biopsy most asthmatics, airways biopsy, and this is really a very rare group, but rarely, but occasionally we will do that because we have a patient who doesn't seem to fit into the Th2 phenotype. So what is how is the immune system involved in the airway inflammation? So airway inflammation is triggered by an immune response, often to allergens. The total IgE level is linked to airway hyperresponsiveness and correlates with asthma severity in the atopic person. But then we also have the cellular response, again, referring to the type 2 T helper cells that are inflammatory mediators, such as the IL-5, IL-4, and IL-13. So these three interleukins are important because we're going to be using biological drugs that either block IL-5 or block IL-4/13. So these two are clumped together, and this one is IL-5, which directly affects the eosinophil. So when you have, in very simple terms, when you have a very hyper-eosinophilic patient, you're going to be looking at a drug that affects IL-5. If you have a patient who's a more mixed picture or has lots of sinus disease or eczema, you're going to be looking at an IL-4, IL-13 drug. So the IL-5 drugs, what do? They regulate eosinophilic production and maturation. So when you're looking at eosinophil production and maturation, you're talking about blocking that, and that would be something that mepolizumab does. If you're looking at IL-5 receptor, and I know it gets a little bit more complicated here, but we're still talking 5, even though it's IL-5 receptor, we're talking about benralizumab, and that actually destroys the eosinophil. So when you've got a hypereosinophilic situation, think about IL-5, think about mepolizumab and benralizumab. If you have the IL-4/13 group, then you're talking about dupilumab. And what IL-4 and IL-13 does is a little bit of a mixture because it affects both the IgE. So it directs IL-4 is directing the B lymphocyte to synthesize IgE. So the IgE gets affected by this drug. And it also, with IL-13, leads to airway eosinophilia. So blocking it blocks the recruitment of the eosinophil to the airway. IL-13 is also involved with mucus gland hyperplasia, airway fibrosis, and remodeling. So this is an exciting drug because maybe it would affect the long-term side effects of poorly controlled asthma, where we know our patient winds up with airway fibrosis and remodeling. Keep in mind, though, that IL-13 is not either blocking the maturation of the eosinophil or killing the eosinophil. It's just affecting airway recruitment. to the airway, the eosinophil coming to the airway. So your serum eosinophils are going to be high, whereas your airway eosinophils are going to be low. So you're still going to have your eosinophils around if you're using a drug that blocks IL-13. So again, want to get rid of eosinophil problems, an IL-5 related drug. You have more complex drugs, you're going to use an IL-4/13 drug. And this one is Mepo or Benra, and this one is Dupilumab. So what is the adult onset type 2 asthma? First off, when is adulthood? This is very unclear in the literature. Some of the literature starts saying adult onset is over 12. Other articles may say it's as high as over 40. So we really do not have a consensus on this. But patients who have adult onset type 2 asthma are less allergic. The presentation is also often following a lower respiratory infection. And you see this in your adult patients who they come in with a viral infection, they're wheezing to beat the band. And then every time they get a respiratory infection, they wind up with an asthmatic reaction. And they may go on to develop severe asthma. The adult onset asthma usually is severe from the start. So these are very challenging patients because they're not used to having asthma. They didn't grow up having asthma. And then all of a sudden we're giving them every drug in the book and they're still wheezing. So this is a tough group. This is a tough group. Early exposures to infections may be protective because you developed your Th1 immunity when you had early exposure to infections. So these patients have a more severe clinical course, a lower remission rate, faster decline in lung function, and lower lung function at the time of diagnosis. Frequently in females, the IgE is variable. The FeNO, if it's elevated, may be associated with nasal polyps. And these patients you're definitely going to be seeing in your clinic. And we used to not understand who they were. Why was this adult getting asthma? We would frequently say. And now we know that that's a whole particular phenotype in the world of asthma. So atopic asthma, by phenotyping, we have your IgE mediated, we have your eosinophilic mediated, your neutrophil phenotypes, and your POC inflammatory phenotypes. And we've sort of talked about all of this already. So within asthma, we also have another subgroup here. We have people who have exercise-induced asthma. And I think we talked about this a little bit the other day. But basically, it's someone who is not just short of breath when they climb the stairs, but they get asthma after exercising for 6 to 8 minutes. And it can last for up to an hour, and followed by a prostaglandin release, and then they get they're improved afterwards. So the treatment of exercise-induced asthma is good overall asthma control. Give your albuterol 10 minutes beforehand, or use cromolyn, which we don't use as much as previously, but use cromolyn 20 minutes before, or use a daily inhaled corticosteroid and/or montelukast. Nocturnal asthma, worse at night. We consider neurohormonal changes, the changes in lung volume. When you lie down, your pulmonary capillaries are more congested. Airway inflammation can be increased. Beta receptor function decreases. We consider GERD, sleep apnea, and heart failure in considering a person whose asthma is worse at night. We can measure peak flows at bedtime and during nocturnal awakenings to be sure that it is an asthma exacerbation. And clearly, we want to make sure that what we're not dealing with isn't sleep apnea, and that we're giving inhaled corticosteroids and asthma medicines to someone whose nocturnal symptoms are sleep apnea. We have a problem in looking at our patients with asthma in that there's so much overlap with COPD. Patients come to the ER all the time, and they don't, maybe more so now than previously, but most patients don't come in saying they have COPD. They come in saying they have asthma because they know they're wheezing. So you can never really assume that somebody has asthma or COPD just by what the ER sheet says, because the treatment, they're going to give them steroids, bronchodilators, and that'll be that. But what you want to be sure that your understanding and your interpretation of what your patient is telling you is based on where they really are. And the features that distinguish are listed here. Asthma is reactive, reversible, peak flow varies, PFT can be normal, peak flow can be normal, and it may be allergic, it may be post-infectious, or it may be the adult onset that we talked about. Whereas the COPD patient ran out of lung. They are always going to have dyspnea on exertion. Not so much the reactive reversible. This is going to be short of breath every time they climb the stairs. They're usually comfortable at rest. They're sitting in front of you looking just fine. But if you do their peak flow or you do their PFT and you look at their FEV1 over FVC, it's going to be less than 70% of predicted. Their peak flow is going to be low, and usually they're an active or a former smoker. So why is this important? Because your goals of treatment for this patient are very different than your goals of treatment for this one. This patient always needs their beta agonist. It's not a sign of being out of control. That's how they live. They always need their beta agonist. They're always going to be short of breath on exertion, whereas this person, we know that we want to get them in a reversible, in their best condition possible, so they don't need their rescue pumps nearly so often. It's important for the patient to understand which they have, or if they have both. Because if they think they have asthma, but yet why can't I walk up the stairs? They need to know that that's because of COPD. And they'll be frustrated if they don't understand that our goal for them is not that they're going to be perfect, because that's not going to happen. Our goal is that we can get them in as good shape and as fit as possible, best control as possible, but they're always going to be short of breath on exertion. Obesity, another big factor. Obesity is, in our clinic, 50% of our patients are obese and 20% of our patients are morbidly obese. So you know right off the bat that these asthmatics are short of breath, baseline, always. Every place they walk, everything they do, they're short of breath. So your inhaler treatment is not going to be able to make that shortness of breath go away. We have to address it directly. Obesity increases the risk of developing asthma. Obese asthmatics have more symptoms. They have more frequent exacerbations. Leptin is pro-inflammatory. Leptin and the hormones and the inflammatory cascade that's present in fat give you worse asthma. But it's worse asthma that you don't want to be treating with prednisone, obviously. Obese asthmatics have reduced response to medication, decreased quality of life. Nearly 60% of adults with severe asthma are obese. So what do we want to do? We want to deal with the obesity. We really want to talk to our patients who have asthma about how we can help them lose weight, how we can help them, how we can help them lose weight. And what we've been doing in clinic also is referring them to endocrine referring them to endocrine, because we've been getting some of them on semaglutide and these drugs that are helping with weight loss. We also refer patients for bariatric surgery. But it's important that we deal with the obesity and not just be aware of it. It's very important that we assist the patient in working on their weight, getting their weight down. Sleep apnea, in severe asthma, as many as 50 to 90% of patients also have sleep apnea. That's amazing combination. And we're going to say a little bit more than that about that. In more moderate asthma, 25 to 50% of patients have sleep apnea. And why is that? Chronic nasal obstruction. If you have nasal polyps, you're going to be prone to having sleep apnea. Increased upper airway collapsibility. If you've been coughing and having inhaled corticosteroids your whole life, you're going to have a weakened upper airway inflammation, decreased pharyngeal cross-section area, so you're more prone to GERD and to reflux. And so this is a back and forth. the mechanical effect of the weight, the reflux, airway inflammation. And then with obesity, you're going to have cardiac dysfunction. With sleep apnea, you're going to have cardiac dysfunction. Leptin changes, weight, nasal obstruction, decreased pharyngeal cross-section area, increased upper airway collapsibility. All these things are shared back and forth with the obese asthmatic. I'm so sorry. Are going to be shared back and forth so that there's a tremendous overlap in taking care of somebody who is both asthma and OSA. Then we have patients with asthma who have cough, and some of our patients have upper airway cough syndrome, which is defined by 8 weeks of cough related to mucus in the throat. It may be postnasal drip, it may be GERD. We have cough variant asthma, and these patients are usually atopic, seasonal, so your IgE patients, and we confirm the diagnosis with a trial of inhaled corticosteroids, and these patients would be bronchodilator responsive. We also have patients who have non-asthmatic eosinophilic bronchitis, and their presentation is cough, and they have a FeNO that's high, and it also predicts that they're going to respond to inhaled corticosteroid. A low FeNO would rule out eosinophilic bronchitis. And these patients don't have asthma yet, but they do have eosinophils in their airway, and their cough gets better with inhaled corticosteroids. When we're trying to tease out our patients, we're going to look at the severity. We have severe, poorly controlled asthma versus severe asthma. And so those are two different things. Poor control due to factors other than the asthma, non-adherence, incorrect inhaler technique, comorbidities. They have a dog or a cat, and obesity, many comorbidities, which we talked about in the last talk. So 90 to 95% of serious asthma is all these factors that we talked about at the previous talk that are impairing their asthma control. And the group of patients who actually have truly severe asthma is only 10 to 15% of asthmatics. And they have poor asthma control despite having taken care of all these factors with over or equal to 2 exacerbations per year, despite high intensity treatment and verified adherence. So in the clinic, when you're talking to the patient, I know everybody asks them, how often do you wake up at night? How often do you need your rescue inhaler? But what I want you to ask as well is, in the past year, how many times did you need steroids? In the past year, how many times did you have to go to the ER or be hospitalized? Because that's going to tell us more about what the actual ongoing severity of their asthma is. So that becomes a very, very important question in then determining what's the best asthma treatment. We have an asthma control test. You all know there's the simple questions, and if you score 19 or more, you're well controlled. Our goal for our asthma treatment is that patients have symptom-free, they're not bothered by cough, chest tightness, wheezing, they have few exacerbations, they don't have to need their rescue pump more than a few times a week, few nighttime symptoms, able to pursue their daily activities, including athletics. They should not be avoiding athletics, they should be being athletic, very important. We want their lung function optimized. And at the same time, we want them having minimal or no side effects from their medication. Educated about how to take care of their asthma, educated about how they're going to use an action plan. But this is the big one. I don't want our patients needing prednisone over 1 time a year. Prednisone or ER over 1 time a year, and we know that we're dealing with a problem, both in obesity, bones, and just ability to function in this world. So GINA guidelines came out recently, and we're going to move on to trying to talk about the medicines themselves now. GINA guidelines came out recently, and with the miraculous insight into what the patients knew all along, the patients knew if you use your Symbicort for rescue, you're going to do better than if you just used your albuterol for rescue. And the patients also knew that lots of them didn't have to take their Symbicort every day. They would just take it if they need it. Well, the GINA people took heed of this. Studies were done, and they decided that the patients were right. So what did they decide? First off, they decided that regular use of a short-acting beta agonist is not good for you. So if you use your beta agonist regularly for just a few weeks, you downregulate your beta receptors, you decrease your level to get a bronchoprovocation, so you're more sensitive, you'll be more easily irritated, rebound hyperresponsiveness, and decreased bronchodilator response from regular use of a short-acting beta agonist. Meanwhile, when you use it, it only hangs around for 15-20 minutes, and it does not have an anti-inflammatory benefit. Higher use of short-acting benefits are associated with significant adverse clinical outcomes. So if a person is getting more than 3 canisters per year, they're associated with a higher risk of severe exacerbations. And for those getting more than 12 canisters per year, is associated with a much higher risk of death. So on the other side, inhaled corticosteroids reduces asthma deaths, hospitalizations, exacerbations, need for oral steroids. But adherence is poor, especially in patients with mild or infrequent symptoms. So they decided they needed a safe and effective alternative for mild asthma. And as you know, what they did was they decided that they would use the reliever low-dose inhaled corticosteroid formoterol. So why is this preferred? Because using low-dose inhaled corticosteroid formoterol as a reliever reduced the risk of severe exacerbations compared with regimens that had just a short-acting beta agonist as a reliever, with similar symptom control. So you had fewer exacerbations if when you got inflamed enough to be wheezing, you got that inhaled corticosteroid in there, as well as a beta agonist, which was both rapid of onset and long-acting. So this is important when you're thinking about using your ICS formoterol, which is what's in Symbicort, for rescue. You want the formoterol because the formoterol is the beta agonist, which is both rapid in onset and long in acting. Salmeterol is long acting, but not rapid in onset. So you don't want to be using that for rescue for sure. So how is it used? To use what we used to consider a controller inhaler for rescue. When a patient at any treatment stage has asthma symptoms, they use low-dose inhaled corticosteroid formoterol as a single inhaler for symptom relief. In step 3 to 5, patients also take inhaled corticosteroid as their daily controller, and in addition, they use it for their rescue. And this is called it's called SMART or MART, which is single maintenance and reliever therapy. So you use your rescue pump and your maintenance pump for the same purpose. When should it not be used? Inhaled corticosteroid ICS formoterol should not be relieved as the reliever in patients who are prescribed a different ICA LABA for their controller therapy. We don't have studies on that. So how do we approach this then? Well, there's 2 tracks. This is track 1. This is the preferred track over here. And this is track 2, which is if you can't get your ICS formoterol, this is what you do. So if you have symptoms twice a month or more, you can use your as-needed low-dose inhaled corticosteroid formoterol. If you don't have this, if you don't have access to this, this is not on everybody's insurance plan, right? And you have to decide what you're going to use. They want you to use an inhaled corticosteroid every time that you need rescue. So the plan is to have 2 pumps, a short-acting beta agonist, and then in addition, use the inhaled corticosteroid every time you need rescue. And this makes good sense because you want the short-acting beta agonist is only going to give you relief for a few minutes. And if you're inflamed enough to be wheezing, they want you to have the benefit of having an inhaled corticosteroid in there. And if you can't have the 2-in-1 inhaler, get 2 inhalers. So if you have just intermittent symptoms, you're going to use your inhaled corticosteroid formoterol for rescue. If you have symptoms most days and at night, you're going to use your inhaled corticosteroid formoterol both as maintenance and as reliever. And again, over here, if you don't have access, you might use your low-dose inhaled corticosteroid LABA and as needed short-acting beta agonist. We don't know what the insurance companies are going to do with allowing this increased use of basically Symbicort, because those doses are metered out for a 1-month supply. So we're going to have to see how that's going to play out. If you have someone who's much sicker and they do need daily higher dose inhaled corticosteroids, they're still going to use the same one for their daily treatment as well as for their reliever. Pardon me, excuse me. And then if they're going to be in the track 2, they're going to have their medium high dose inhaled corticosteroid LABA and then as needed SABA. So this is the same as we do all the time now. These patients then may go on to need oral steroids, they may go on to need biologics, they may not go on to need our for additional step 4 and 5 asthma medications added. Is that clear? That's a big change, but I think it's a very good sense change. Does anybody have any questions?
I guess I have a question.
Yeah.
It's not really regarding treatment per se, but what do we do with a patient who is uninsured and needs that inhaled corticosteroid, and like the out-of-pocket cost is just too much for them on a monthly basis, and like albuterol is not really cutting it?
Right. So this is a very important issue. And the first thing would be to refer them to the HEAL Center so that they can apply for Medicaid. The other thing is, if Dr. Andrelli is not listening, I always keep a supply in the drawer, but you didn't hear me say that, but this is part of life in New York. But also with the social worker, we often apply for a grant because not everybody who can't afford these very expensive drugs can get Medicaid. You can be in the in-between and then you're in trouble. But we can apply for a grant, and most of the drug companies, if you're in that middle lower income range, will give you a year's supply for free. So we have a lot of patients that we do that for, and it's thank you for bringing it up, because it's good to be aware that this is available to patients, that the companies will give grants to cover a year's supply of the medication.
Thank you.
Okay, so next slide. Okay. So here's you'll see this sheet from the GINA guidelines. And again, they always emphasize, make sure, that they got good technique, that they don't have the mice, the roaches, the mold, that other things are being addressed. So confirm that you have a holistic approach to the background of addressing the modifiable features. But then you can see for step 1, 2, 3, 4, 5, you're going to have as needed low dose inhaled corticosteroid formoterol for your rescue pump. And the alternative, less favored approach is to use as reliever your short-acting beta agonist, and if you're not already on your inhaled corticosteroid, use the low dose inhaled corticosteroid along with the short-acting beta agonist as your rescue. Now, the other thing that they changed in the GINA guidelines is they added in these drugs that we're using now with such great success. So your anti-IgE, anti-IL-5, anti-IL-5 receptor, and your anti-IL-4/13 are listed on your step 5 for your GINA guidelines. So this is really wonderful, really, really wonderful. And again, for the same question that Bailey was asking, how do we get these expensive drugs for these patients? Well, what we do is we put the application to the drug to the Mount Sinai pharmacy, and they are expert in getting prior authorization. However, if the patient's insurance will not cover it, they also will get a grant. All these drugs, we've not had any patient who couldn't get the drug because of insurance. There are grants available for each of these drugs. So don't withhold your patients from consideration for these drugs, because they are available. And it's in working with the Mount Sinai pharmacy, it has been really, really wonderful that they're able to get these drugs for our patients who don't have, the insurances, or, for whatever reason, can't get these drugs just from the pharmacy. Well, you can't get them just from the pharmacy. You have to go through a specialty pharmacy, I should say that. What about tiotropium? Teotropium is now added on, right, for your step 4-5 group. So tiotropium, which is your LAMA, we always thought in the past about giving tiotropium for patients who had COPD. But tiotropium in asthma is a significantly good tool. And remember, many of our COPD patients do have a certain amount of remodeling. So they have a certain amount of overlap with COPD anyway. But if you look at the FEV1 of patients receiving on their asthma treatment, receiving placebo versus tiotropium, the FEV1 went up, and also the time to exacerbation goes down. So this has been a good addition to our asthma management, and is definitely on your step 4 and 5 algorithm for treatment, to add in tiotropium, which is Spiriva, and to your regimen. So if you're looking at using, you can add in Spiriva, or if you're using the inhalers that are once a day, you could use your Incruse, which is a LAMA, or you could get all 3 medicines in one, which is your trilogy, which would have inhaled corticosteroid, long-acting beta agonist, and your LAMA. Those inhalers, though, do not have the formoterol, and we want the formoterol because of the use for rescue. But tiotropium is part of asthma management. Additionally, we have in the same level 4-5, actually more in the level 5 level, effect of Th2 on asthma exacerbations and quality of life of adults with persistent uncontrolled asthma. So we have, for uncontrolled asthma, no hearing impairment, no prolonged QT, azithromycin 500 milligrams 3 times a week, and we were able to see reduced exacerbations annually, and reduced proportion of participants with exacerbations. Azithromycin is an anti-inflammatory. We're always concerned when we're using it in chronic situation that we're not giving it to somebody who has MAI as an underlying illness, because we would induce resistant MAI. There's some change in the bacterial flora of these patients, but they actually do very well. And so it's been a significant addition to the to our asthma regimen. So we've already covered this. We want to prevent exacerbations. We want to optimize lung function. But the biggest thing here is we want to have our patients not to need prednisone. And this is, okay. So here we have, let's just break the drill here and just look at a case for fun. So see what you guys think. 65-year-old male, referred from the ER, so we don't know what he's got, for asthma. Former smoker, appears quite comfortable, but was wheezing upon entering the clinic after climbing the hill in Morningside Park, and was given a neb treatment by the nurses. The peak flow after the neb treatment was less than 50% of predicted for his age and height, and the staff wants to send him to the ER with such a bad peak flow. He notes 1 year of progressive dyspnea on exertion and uses his albuterol 8 times a day. His spirometry shows severe airway obstruction, and he is bronchodilator responsive. He gets 200 cc's and 12% increases in his FEV1 post-bronchodilator. He was given an ICS LAMA in the ER, which helped somewhat, but he still has exercise limitation. But because of his very bad peak flow, the staff wants to send him downstairs so what would you do? Send him to the ER now, give him 3 nebs, or add a LAMA and prednisone and tell him this may not be asthma and exercise limitation may continue. Anybody want to say anything? Does he have asthma? Sonal says he does. What do you think, Sonal?
So he does have improvement in his FEV1 or increase in FEV1 post bronchodilator, and that's a 12% improvement. So I think that he does have asthma.
Anybody else have a thought?
I think he has a little bit of both, but more so asthma.
Oh, okay. Now this is a really amazing thing. In COPD, in some of the studies, 50% of patients with COPD will have significant bronchodilator responsiveness. So just because, right, I know this is like goes against everything you learned in medical school, but just because they have bronchodilator responsiveness, it still may be COPD. So, so we have to keep that in mind. This alone isn't gonna help us. What do you make of the peak flow? It's a terrible peak flow. Less than 50% are predicted.
Probably like chronic bronchitis related.
Or he has COPD.
Yeah.
Because he looks comfortable. An asthmatic with a peak flow less than 50% are predicted is going to look terrible, right? This person, they're wheezing, but they're comfortable after they sat down and they have a terrible peak flow. So I'm suggesting that maybe this person has COPD, whether they have an asthmatic component or not, they may. But I think that what we have to consider is that they may have COPD. Now, would you send this person to the ER? Would you give them nebs? Would you give them a LAMA and prednisone for COPD exacerbation and say, let's do some testing and see? What do you think? I think lots of times we're going to do in this kind of a person, we're going to do a CBC with diff because we want to do that in all of our asthma patients. You also want to do that in our COPD patients, right? Because a patient with COPD and eosinophilia, we're going to give the inhaled corticosteroid more early. That's from your COPD talk. So we're going to do a CBC with diff. I would do an asthma profile. I would do a pheno, right? We want to see if they have eosinophilic inflammation in their airways. I'd want to look at the chest x-ray, see if they have any evidence of emphysema or CAT scan, possibly, if we're still in question. But I think that this is being aware that I think it's important to be aware that COPD can be bronchodilator responsive, and that they can be comfortable when they have terrible lung function. But don't ask them to walk. When they're sitting there, they're okay. Okay.
Dr. Sullivan, I'm sorry to interrupt.
I'm sorry.
Some of the interns are bringing up, questions regarding this patient's workup. Should it be done inpatient or outpatient? What will you suggest we do in this case?
Well, I think you can get so much from the history. You get so much from the history. Are you reacting when you have a cold and otherwise you're okay? Are you reacting when you clean the house, when you're around, etc.? I have a little drill. Are you, springtime and mold, cats, dogs, la, 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 la. Do you react to those things? Are you short of breath on exertion all the time? Or sometimes you have good weeks and you have other weeks when you're bad weeks. If you have good weeks, really good weeks, then you don't have COPD, because COPD is always having dyspnea on exertion unless it's very mild. Do I send an IgE and a RAS test on an inpatient? Sometimes I do if I think they won't show up and I can't get it, but I usually do that as an outpatient. A CBC with diff, which is so useful, is completely useless if you've gotten a single dose of steroid. So there's no point in doing that. Will I do a PFT inpatient? I will, not all the time, but sometimes I really want to know how bad that airway obstruction is. So I will do the spirometry inpatient. Will I do a pheno when they're on steroids? No, because it's not going to help us. So it's, you put the whole thing together. Okay. So here is distinguishing asthma from COPD. I get tight when I dust the house and albuterol relieves. That's asthma. I have dyspnea on exertion all the time. So you have asthma, you have COPD, and then many of us are asthmatics smoked. So as Richard said, maybe they have both. So there's a lot of overlap. And the treatment of overlap patients is different in that we have the inhaled corticosteroid as part of the regimen earlier. A straight COPD patient, I'm not going to give them inhaled corticosteroid early on in their course because that makes them have increased risk of getting a pneumonia. But if they are a COPD patient who has over 300 eosinophils or they have a history of asthma, then I'm going to start their inhaled corticosteroid earlier. But there are definitely a significant group of patients who have both. Okay, so, and then you have the asthmatic who has remodeling, and they've gotten into a COPD type of PFT. So in asthma, you have acute inflammation, then you have chronic inflammation, and then you have airway remodeling. And so many of our most, especially elderly, long-term asthmatic patients, maybe undertreated over the years, have airway remodeling. So they are starting to mimic in their PFT and in their peak flow, their airflow obstruction, which has an irreversible component now because they have had so much remodeling. And that's one of the hopes for Dupi, which is the IL-4, IL-13 drug, which does seem to affect airway remodeling is to a certain degree. So this is something that's being researched all the time, trying to figure out how we can prevent the airway remodeling, but also be aware that some of our asthma patients already have airway remodeling. So in the clinical consequences, if you've got smooth muscle mass increase, which you get with long-term asthma, the airway is full of muscle. So when you get back bronchospasm and you have a thick muscle layer in your asthma, in your airway, you're really going to get severe bronchospasm. Mucus gland increase, so you're going to get more mucus production, ongoing inflammation, fibrogenic growth factors, so you're going to get basement membrane thickening, and then elastolysis. So as you get older, elasticity decreases, and so your airway becomes floppy and starts to mimic COPD more and more. So there's the clinical consequences of remodeling in the long-term asthma patient. Okay, so now we have another case. Let's see what we do with this one. So 50-year-old female presents with two years of shortness of breath and wheezing, especially following upper respiratory infections. All right, so we know we're talking about adult onset problems. She has severe sinus disease. She's a never smoker, no childhood asthma or allergies, no aspirin sensitivity. She's compliant with her inhalers, has no exposures at home. You give her Symbicort and albuterol with some improvement, but she still needs her rescue multiple times a week and has had 2 courses of prednisone in the year. So this is a familiar picture, yes? So let's see what her PFT looked like. So here we have her PFT. We just put here her FEV1. So pre-bronchodilator, her FEV1 is 2.1 liters, or 56% of predicted, really bad. Her FEV1 post-bronchodilator is 2.46, which is 65% of predicted. So she did go up by 16% and more than 200 cc's. So she is bronchodilator responsive. Her FEV1 over FVC is 65% of predicted. So she's less than 70%, right? Or what we actually use now for the ratio, cutoff ratio for COPD is the lower limit of normal, but she's below that. And her FeNO is a whopping 106. So This is the, if you remember, we talked about FeNO, 0 to 25 was normal, 25 to 50 was indeterminate, and over 50 was high. So hers is like very high. So would you do any additional testing to further evaluate her? What would you think you'd want to do? Anybody?
Sarah, you think you can?
What's that?
I'm just calling out a name, Dr. Sullivan.
What's that?
I'm volunteering Sarah. There you go.
Yes.
Maybe like getting like a CBC with diff, look at her peripheral eosinophils.
Right, exactly. Sarah's on it. Okay, so her absolute eosinophils were, I can see it, but you can't. Let me see if I can move this out of the way. Her absolute eosinophils were 900. Now notice I didn't say percent. You don't want to look at the percent because it's always it's difficult to interpret. You want to look at the absolute number. So her absolute eosinophils are 900. Remember, we said that we start thinking about those biologics. You can think about them over 150, but we really think about them over 300, especially since she's had steroid courses, right? So we wanted her eosinophil count. Would you want to do anything else? Would you want to do a RAS test? Would you want to do that asthma profile, what we call the asthma profile? Why not? Right? So she gets an asthma profile done, and she is class 2 allergic to dogs and several trees, but nothing else. And she's only class 2, and her total IgE is 186. Right? So where is she on our, she's right in the middle of our graph, right? Because the childhood onset had high IgE and lots of allergies. She doesn't have a high IgE. It's a little bit high, but it's not 1,000. It's not 800. It's a little bit elevated, and she has a little bit of allergy. So she's looking like an adult onset asthma. Am I right? Right? And we check for Aspergillus because we always worry about Aspergillus antibodies in people with severe asthma in case they have ABPA. And she's not allergic to Aspergillus. Let me say one more word about the Aspergillus thing. You have two kinds of antibodies to Aspergillus. You have your IgG antibodies and you have your IgE antibodies. The IgE antibodies are what's relevant for ABPA and for asthma. The IgG antibodies are more related to having a systemic immune response to the Aspergillus and not an allergic response to the Aspergillus. So she doesn't have she doesn't have IgE to Aspergillus, and she does have eosinophils. So what are you thinking? What should we do? She's pretty sick. Would you want to give her a biologic? She's been on steroids repeatedly. Maybe. Noble, do you have a, what do you think?
Add mepolizumab.
So yeah, we could add, so we're thinking, wow, she's an eosinophil person. So we had two drugs that we were especially thinking about for eosinophil targeted therapy, which is mepolizumab, anti-IL-5, or benralizumab, anti-IL-5 receptor antagonist. So I would agree with you. I would go with the mepolizumab for her. So let's just take a brief look at our biologics. Right, this is very simple. We have our mepo, and that's for eosinophil maturation. We have benra, eosinophilic destruction. And both of these would be fine for somebody with eosinophilic asthma. And mepo you could also use for hypereosinophilic syndrome or EGPA. So I agree with you. I would give her one of these two drugs. Would we want to give her omalizumab, which is Xolair? That's more anti-IgE, right? That's for the young childhood onset, atopic asthma, urticaria, anaphylaxis, the more allergic person. And then would we want to give her Dupy? Well, she doesn't have much IgE and she has a lot of eosinophils. So I'm thinking maybe this would be the better drug for her. But you could give her Dupy, it would be fine. It would work. It would work pretty well, actually. And especially because she has chronic sinus disease. Dupy is for severe asthma, either atopic or eosinophilic, especially if they need steroids. It also works for atopic dermatitis, and it also works for chronic rhinosinusitis and nasal polyposis. But since it reduces the recruitment of eosinophils rather than their either maturation or their survival, I'm going to go with an anti-IL-5 drug because she's got 900 eosinophils. She's got a lot of eosinophils. Does that make sense? So what is your treatment for an asthmatic with daily symptoms and waking at night once a week? What are you going to give that asthmatic?
Symbicort in the chat.
Bailey just wrote on the chat, Symbicort.
There's Symbicort.
Yeah, Symbicort, sure. We're going to do Symbicort. That's going to be good. And if they don't respond to that, we could also consider adding in a LAMA. And if they didn't respond to that, we could consider adding in azithromycin low dose. But we also, if we couldn't get good control with the Symbicort and she was needing prednisone repeatedly, we would think about the biologics, right? What do you do with an asthmatic with a BMI of 45? How do you approach this patient? They have an exacerbation. I'm going to go crazy because I do not want to be giving that person prednisone, right? So I'm going to be very attuned to trying to do everything to help them lose their weight while trying to get a good asthma control without use of prednisone. It's very, very tough situation. And this is what happens to our patients. Have you seen patients who look like this? Right, prednisone, right? And prednisone is a disease unto itself. So 45% of patients with severe asthma use systemic steroids to control the disease and prevent exacerbations, right? You see this in the clinic all the time, I'm sure. Oh, I take prednisone. Oh, my doctor gives me prednisone to take every time oh my gosh. And then you look at them and they look like this, right? And they have no bones and they have diabetes and their knees are starting to go, so they can't walk and they can't exercise. And we have that old vicious cycle, right? So what's the problem with steroids, oral steroids? Non-selective, multi-organ toxic effects, diabetes, obesity. Did they affect your heart? Yes. Hypertension, dyslipidemia, premature CAD, arrhythmias, make you hold on to fluids, affect your skeleton, vascular necrosis, osteoporosis, myopathy. Do they make you crazy? Yes. Do they affect your eyes? Yes. Broad immunosuppression? Yes. This is very, very bad. So my whole goal in life is to get my patients off steroids, systemic steroids. And so that's how we approach these asthma patients. So we got your severely poorly controlled and you got your severe asthma. Do they have all those things that we got to get the technique and get rid of the dog and the mold, et cetera, or do they have really bad asthma? We have to put them on a more intense treatment. So how do we think about it? Is the diagnosis correct? Maybe they have sarcoid. Maybe they have something else. We got to think about that. Are their meds being taken properly? Are they compliant? How many of you call the pharmacy to see if the patient's filling their prescription? I do. Amazing what you find out when you call the pharmacy. And you can actually, there's a way in Epic where you can see how often your patient fills their medications. So that's a very important, because the patient's so embarrassed, they're not going to tell you. Do they have reflux? We know that reflux may be a player here. Is their anti-inflammatory medication adequate? Maybe they're severe because they need a higher dose of inhaled corticosteroid. Do they have sinusitis that's driving this ongoing postnasal drip inflammation infection? Are they working in a pet shop? Do they have ABPA? Do they have unrecognized allergens? So we went through some of these things in the beginning, trying to look at reversible things that we can do. So do they have poor symptom control? Are they getting steroids? Are they getting in the ICU? Do they have a bad PFT? Are you unable to control their asthma? You try to decrease the systemic corticosteroids or their high dose inhaled corticosteroid, and they get worse. You got all of that, and that's in the definition of severe asthma. So what are we going to do? We're going to do the IgE, the allergy test, the CBC with diphthenitric oxide, the spirometry. Look at the pharmacy records. Consider a methacholine challenge with laryngoscopy. What am I looking for there? Vocal cord dysfunction, right? Do you see patients who have vocal cord dysfunction? You know where you see them? You see them in the ICU because they get intubated because they make so much wheezing noise. Nobody knows, it gets terrifying. They say, oh my God, this person has such vocal cord dysfunction, has such bad asthma. And then the minute you intubate them, silence. It was all upper airway, right? And if you can help that person who has vocal cord dysfunction, it's life-changing. We now have access to speech therapy. We're able to help them get control of their vocal cord, their paradoxical closure of their vocal cords. Anyway, so in this, but that's one component here. Evaluation goes on. Would we get a high-res CT in a severe asthmatic? Yes. We want to see, do they have bronchiectasis? Do they have bronchial wall thickening? Do we think they have ABPA? We might do a barium swallow. We might do a sinus CT. We're worried about that they have chronic sinus disease. Maybe they even have EGPA. Should they have a cardiac evaluation? Will the wheezing of heart failure respond to beta agonists? Yeah, it'll make you feel better. So sometimes we have to do a cardiac eval because we don't know if it's cardiac or not.
Do you want to take a short break?
What's that?
You want to take a short break?
Oh, sure. Do you want to take a short break?
Maybe we can take a short break. Yes, if that's okay with you, Dr. Sullivan. We still have plenty of time to continue with the lecture.
Okay.
So you guys, 5 minutes, turn off your cameras, make sure nutrition break, eat something, and we'll come back, Dr. Sullivan. Thank you.
Thank you.
All right, guys, if you want to turn your cameras back on. Thank you, Dr. Nasal, and I hope you hydrated as well.
Yes, indeed. Thank you.
We have candy in the back if you want to grab some.
Okay, so let's say a few words about conditions that coexist with asthma, ABPA, and what used to be called Church-Strauss and now is called EGPA. So ABPA, we see this it's not a rare disease. And what it is a hypersensitivity reaction or an allergic reaction to chronic airway colonization by Aspergillus. And these patients present with severe asthma, recurrent episodes of airway obstruction with central bronchiectasis. They have their mucus I always ask what color the mucus is, because when I hear brown, like bells go off, because so often the mucus of ABPA is thick brown plugs. And they always used to tell us it was like a tree, but definitely the shape of a bronchus. Fleeting infiltrates, extremely poor control, IgE over 1,000. And so they have the allergic to Aspergillus and increased IgE. They may have the more systemic reaction to Aspergillus with an IgG as well. But this is not the big one. This is the important measurement for ABPA. So the treatment is steroids slowly tapered over 3 to 6 months, combined with either itraconazole or voriconazole or isovuconazole, depending on where you are in your ketocon or your antifungal regimen. As the years go by, they keep adding ones. The problem here is steroids slowly tapered over 3 to 6 months. I've been talking about bad steroids, and I still do believe this, but that's the recommendation for ABPA. There are no large studies looking at the use of biologics in ABPA. There are only case series and case reports, but we have been starting to use biologics in our ABPA patients with great success, and also with more rapid tapering of the steroids. But they definitely need the anti-inflammatory effect over a period of time, because the airway is getting destroyed by the inflammation in the airway. And I have a picture of the CAT scan of an ABPA patient. And here you can see the bronchi that are what we call central bronchiectasis. The diameter of the airway is thickened. And these patients develop plugs in the airway, and the plugs will actually be this kind of size. They're huge, and they fill up the airway. They have a high density if you measure the density on them. And this thing is a ball of fungus that's growing in there and causing damage to the airway. So when the fungus ball empties out, you wind up with this, which is a very damaged airway. So ABPA is something we definitely want to keep in mind in our serious asthmatics. And in your asthma profile, this IgE to Aspergillus is included in your asthma profile. So always look at that, see what it is. If it's very, very high, even if they don't have ABPA, they usually have a more severe form of asthma. In our ABPA patients, they may present at the time of an intense mold exposure. Sometimes there's been a leak. Sometimes with Sandy, we had patients coming in who had mold exposures in their home. And we always wind up having a patient who the ceiling fell down because it was so badly destroyed by water damage and mold exposure. And that then leading to a onset of ABPA or a flare of ABPA. It can exacerbate and diminish. So these patients are definitely present in our population, and we want to identify them and take special care of them. Then you have something called EGPA, which is eosinophilic granulomatosis with polyangiitis. And what I like to think about with this disease, It's an eosinophilic disease, but it starts off with eosinophilia, and then you get eosinophilia in your organs, sinus or lung, and finally, and peripheral nerve, and then finally you get eosinophilia even in your blood vessels. So it's a disease that progresses over a number of years usually. So eosinophilia, then organ involvement, then blood vessel involvement. ANCA is positive in 40 to 60% of the patients. So you can definitely have EGPA and not have a positive ANCA. But what distinguishes it is that you have vasculitis along with the eosinophilia, not just asthma and not just infiltration of the lung and the sinuses, but actual damage to the blood vessels, which then is very serious and has cardiac implications as well as systemic vascular injury elsewhere. So and two important branches come off of asthma. So in our severe asthma patients, how do we think about it? So we have patients with allergic eosinophilic asthma. We have patients with allergic non-eosinophilic asthma. We have patients who are non-allergic or do not respond to anti-IgE treatment and have eosinophils. So any of these charts, I think, you just have to think them through. If you've got eosinophils, you're going to get an anti-IL-5 or anti-IL-5 receptor as your first choice. If you have a mixture, you're going to think about Dupi, which is an anti-IL-4, anti-IL-13. If you're young and you have a lot of IgE and you're not eosinophilic, you could have either your Xolair, your Omalizumab, or your Dupi, which has also anti-IgE properties. If you have a very, very high FeNO, we jump to Dupi right away, because somehow this is IL-13 is in charge of nitric oxide in the airway. And if you are high in nitric oxide in the airway, you do very well with Dupi. So it's pretty straightforward. What I want you to think about with these drugs is that when you have your sick patients, please consider them for these biologics because they work so well. What do? Well, they reduce exacerbations is their big effect. And by reducing exacerbations, your patient's not winding up in the hospital, in the ER, and not winding up on prednisone so much. So steroid dose goes down. Improve symptoms, improve quality of life, big time. And disease modifications to prevent asthma over the long term. So we're hoping that we don't have the remodeling that is so problematic for our patients. So here's our group, and so we're thinking in here, your eosinophilic Th2 group. There's where we're thinking about our anti-IL-5 or anti-IL-5 receptor. When we have an overlap between these groups, so they have some IgE, they have some eosinophilia and serious asthma, we're thinking Dupi. If they only have IgE and they're this group over here, we're thinking of Xolair. Does that make sense to people? It's once you get the sense of the eosinophil, it's pretty straightforward, I think. I think one thing to keep in mind is that all of these drugs now you do not have to go to the infusion suite. The patients, they get it like delivered to the house in a form that's like an EpiPen. So they just have to jab it into their leg or the fat on their belly. It's very easy to do. We have them come to the clinic a few times to practice, and then they do it on their own. Very easy. So definitely, please do consider these drugs for your patients. So where do we get the absolute? I think this slide is out of order, but anyway, you start to consider these drugs when the eosinophil count is 150. The higher the eosinophil count, the more they're going to get a benefit from the drug. We especially look at these drugs for people with eosinophils over 300 and over. So here's another patient, 50-year-old female, never smoker, 2 years of short of breath and wheezing, severe sinus disease. FEV1 70% of predicted, FeNO is 70. Again, insufficient response to Symbicort, compliant exocrine technique. She's on steroids. She's gained 15 pounds and has diabetes. Her eosinophil count is 60 cells per microliter when she's on prednisone, but it's 600 when she is off prednisone. So you want to do your prednisone measurement when they're off prednisone. And so when you look at many of these people, they stay on prednisone so often that all the eosinophil counts are low. So what you want to do is catch them when they're off the prednisone so you can get an eosinophil count because you're not going to be giving them if the drug if they have 60 cells. But 600, you're going to be definitely looking at having a consideration for a biologic. This is repetitive here. So here's your IL-5, 4, and 13. The IL-4 and 13 is involved with both the beta cell and the IgE and the eosinophil, and the IL-5 is directly responsible with the eosinophil. Those patients who have non-type 2 inflammation, who we don't know how to really give them good treatments, they're reacting to irritants, pollutants, microbes, viruses, and they have a different cascade. And the center of this cascade is the neutrophil, or sometimes their cascade is they don't have any cells in their airway biopsy. So this is a different group. This is your non-Th2 group. So what are we going to do with our non-Th2 neutrophilic or paucigranulocytic? Well, first off, we're going to try to identify them. Biomarkers negative. It's associated with obesity, smoking, infection, lack of response to steroids, and the treatment. Weight loss, bariatric surgery, if neutrophilic, macrolide antibiotic, the low dose azithromycin, secretion clearance, pulmonary rehab. If you wind up getting an airway biopsy and they are paucigranulocytic, you're thinking about increased use of bronchodilators because they're not going to respond to inhaled corticosteroids, and even considering bronchial thermoplasty. We have now newer biologics that are going to be targeting these pathways on this side, but we don't have them yet. They're in development. But bronchial thermoplasty is one of the things that's being considered, even though we don't have full recommendation for that as a treatment yet. So just a word about the drugs themselves. Omalizumab is a recombinant humanized anti-IgE antibody. It binds to the IgE with high affinity, and it takes it out of circulation, takes it out of activity. So you're not going to be having it interacting with your eosinophils, your dendritic cells, your basophils. It results in a marked reduction in free IgE because it makes a complex. Downregulation of the IgE receptors, reduction of tissue eosinophils, reduction of bronchial IgE, and the dose range is recommended for between 35 and 700, or having perennial allergens. But frankly, we've never had a problem getting omalizumab for patients who have IgE even over 700. So we just ask the drug company and they do give it. The concern is that since it binds to the IgE, would it be overwhelmed by the amount of IgE that's there? And so that's one of the considerations, but patients do get a response even when they have very high IgE. The omalizumab is administered sub-Q every 2 to 4 weeks, according to the level of the IgE. It stabilizes symptoms, improves quality of life, reduces exacerbations. Its response is related to the level of FeNO. It's not related to the level of IgE, which is interesting. You have to have an EpiPen to go on omalizumab, but they used to think that the level of anaphylaxis was increased because of omalizumab, but it's really because these patients are innately prone to anaphylaxis. We're now able to give it at home. So you would get, if your patient is going to go on omalizumab, they could get the first 3 doses in the infusion suite, and then they sit for a period of time afterwards to make sure they're not having a reaction. And then after that, they're able to do it at home. And they'll get the delivery of the omalizumab from the pharmacy, from the specialty pharmacy, either every 2 weeks or every 4 weeks, depending on how high their IgE is. this is long-term concerns. Sometimes people do come off it, just very simply, sometimes they come off it and they stay okay for a number of years. Sometimes they do have to go back on it. MEPO, anti-IL-5, eosinophil maturation, indicated in severe uncontrolled asthma with high eosinophil count. Half-life is 20 days. Blood eosinophils are decreased by 50%. Exacerbations decreased by 50%. Reduction of all corticosteroids by 50%. 1 month injection. You need to have your Shingrix vaccine beforehand because there is an increased incidence of developing shingles after starting MEPO. 3 big studies, DREAM and SIRIUS and MENSA, they all showed that had a decreased exacerbation rate, decreased steroids, and some significant improvement in FEV1. So now the GINA guidelines are recommending these drugs. Benra, severe asthma with high eosinophils, antibody to IL-5 receptors. It's cytotoxic to the eosinophil. So within hours, the patient's eosinophil count goes down to 0. It's amazing. I had a patient, I gave her the first shot. We got her CBC that afternoon, and it was already down to 0. It's so fast. It's very, very, very effective in knocking out your eosinophils. You worry, what's going to happen to people with no eosinophils at all? And we have not seen problems with people developing parasites, parasitic infections, especially because you worry you need your eosinophils for your immunity to parasitic infections. And it's wise to be checking people for especially Transiloides antibody before embarking on these anti-eosinophil drugs. Best responders, high exacerbation rates and high eosinophil counts. And then Dupi, your anti-IL-4, anti-IL-13, increased FeNO, eosinophilic asthma, atopic asthma, moderately severe or severe, also works for dermatitis or also works for nasal polyposis. The higher the FeNO, the more I'm going to want to use Dupi. And it may have a role in preventing airway remodeling, because remember it said it blocks the recruitment of the eosinophil, but it also blocks the proliferation of fibroblasts and smooth muscle and collagen deposition. So here's your IL-4, IL-13, airway recruitment is blocked, but also you have this, what we hope to be a very good effect on the chronic side effects of asthma, epithelial and mucus production, increased basement membrane collagen deposition, etc. And then we have bronchial thermoplasty as the last thing, where at bronchoscopy, a heated probe is put into all the airways. It takes several hours to do this, and where the muscle is destroyed, thinned, so that there's not such muscular hyperplasia. And for the patient who is not eosinophilic, not inflammatory, they may get a benefit from this. There's a very, very high placebo response to bronchial thermoplasty. So that's why it's always been a problem, because the placebo response to it, imagine having a many-hour bronchoscopy that's got a big placebo response. So we're uncertain, but there does seem to be a role, and we do have access to this for the patient who we see as palsy inflammatory form of asthma. So that's the last slide that I wanted to go over. I'd be happy to take questions. Happy to, if you have questions with your patients, just send me a text or an email. Happy to get your patients on these drugs, send them back to you so you can manage them. I think it's important to utilize these drugs. It's important to do the whole asthma drill from the beginning to the end. And I know you do all these things, but encourage your patients not to be afraid of the injections because they really work. So any questions you have, I'm happy to take. Nary one. Okay.
Looks like there's nothing in the chat either, but people are thanking you, Dr. O'Sullivan, for a fantastic lecture. Thank you so much
Oh, it's my
for your
pleasure.
time.
Lots of fun. Fun for me. I hope it was fun for you.
It was, and it clarifies so many things that we do see in clinic, and when we come to your subspecialty clinic as well. It's good to have this time with you. Thank you so much again, Dr. Sullivan.
My pleasure.